Good morning, everyone. Welcome to this week's episode of new workshop series. Today we are continuing with module 2 of Women's Health Physiotherapy. And the topic for today is assessment and physiotherapy management of urinary incontinence. Hope it will be educative and informative session. Thank you all. And the presentator for today is Dr. Sadat Abubakar from Department of Physiotherapy, Bayero University, Kano. You are welcome, Ma. You can start.
Thank you very much. Good morning and a very good weekend to you. My name is Sadat Abubakar from the Department of Physiotherapy, Bayero University, Kano. Here to give overview and assessment of urinary incontinence. We thank the management of Institute of Rehabilitation for the opportunity given to us. We are really grateful. As a form of introduction, we know that physiotherapy plays a vital role in so many aspects of rehabilitation, including incontinence. So why do we need physiotherapy in incontinence? There are some reasons or more, but here we have few or three of them to discuss. One is to take a holistic approach to assessment and treatment of all patients. Then the assessments include history of the present condition, detailed assessment of urinary and bowel symptoms, obstetrics and gynecological history, other surgical history, and drug history. We also have vaginal and/or an rectal examination when necessary. The outline of the overview will take into consideration the definitions, the types, epidemiology, the etiology and symptoms. We have the risk factors, the evaluation or diagnosis, as well as the differential diagnosis of incontinence, the red flags, and some of the outcome measures in the management or assessment of incontinence. As a form of definition, urinary incontinence is involuntary leakage of urine, which impacts patients' health and quality of life. Urinary incontinence means that one has a difficult time controlling the bladder. As a result, one cannot hold the urine until he or she make it to the bathroom. Depending on the cause of urinary incontinence, this could be with a sudden urge, or it could just leak without one realizing he or she needs to pee. Then we can have an overview of the anatomy of the lower urinary tract. We all know the anatomy, but just let's recap ourselves of it. We know that the bladder is a hollow muscular organ of smooth muscle fibers, which is the detrusor muscle, which is innervated by the parasympathetics. And we have the trigon, which is the area between the two ureteric orifice and the urethral orifice. It composed of two smooth layers, which is continued with the smooth layer of the urethra. The superficial layer are devoid of parasympathetic. Here we have the diagram showing us about where the urethra is. We have the mucosa of the urethra. We see the trigon here, which is just like a triangle, an inverted triangle, showing us the urethral orifices. And we can see the urethral sphincter. We can see the external and the internal urethral sphincter. We can also see the neck of the bladder, which is just a recap for us. This is also another view for record. The normal urethra is about 3 to 5 centimeters in length. It's lined by transitional cells, and its proximal half and the distal part the distal and the proximal part is by the stratified squamous epithelium layers. Beneath this is a rich vascular plexus and rich layer of collagen, which contributes about 1/3 of the urethral pressure. The longitudinally smooth muscle, which is contractions, leads to urethral shortening and opening. And we have the striated muscle, which is located in the middle third of the urethra, circularly arranged. All the previous structures were called the intrinsic sphincter. The extrinsic sphincter, however, consisted of the levator ani, which had no direct connection with the urethral situation, situated at the middle and lower thirds of the urethra. Both intrinsic and extrinsic sphincters call the positive closure pressure and maintenance of the incontinence. This is just showing us a cross-sectional view, and we can see this, the bladder, we can see the internal and the external sphincter, which was mentioned in between the urethra. Then the continence control is by having the intra-urethral pressure, which exceeds the intravesicular pressure, and it's approximately 1/3 of the urethra, which should be intra-abdominal organ for closure of urethra. And they are both intact, the internal and the external sphincter. The two ureters is supported by the pseudourethral ligament and is surrounded by fascia. Let's have a recap of the physiology of the lower urinary tract. We have the storage phase, which is the first sensation of bladder feeling, and it's about 150 to 250 mils. The bladder capacity, however, is found to be 400 to 500 mils. Pressure inside the bladder is usually less than 10 centimeters to 300 mils, till about 15 centimeters water for 500 mils. Impulses from stretch receptors to sacral roots, thus the S2 to S4 to spinal cord and to the basal ganglia, can be transmitted and increase bladder feeling, which leads to the cortical stimulation. And at that time, we have the voiding phase, which is at the suitable time and place, the cortical inhibition is released. A relaxation of the pelvic floor occur, and also the relaxation of the intrinsic sphincter. Then the physiology of micturition, we have the bladder innervation, which is innervated by somatic, parasympathetic, and sympathetic. As urine fills in the bladder, the detrusor stretches and allows the bladder to expand. Approximately 300 ml in bladder before the brain recognizes the bladder fullness. This is the diagram showing us that adrenergic receptors and alpha adrenergic and beta adrenergic receptors. So what are the impacts of urinary incontinence on the quality of life? Yes, we know urinary incontinence is something that is actually disturbing and affects the overall quality of life, ranging from physical, which include limitation or cessation of physical activities, to psychological, feeling guilt and sometimes depressed of having this condition. Sometimes there's loss of self-respect and dignity, feeling that leakage, it's giving someone a low self-esteem. And then there's fear of being a burden, thinking this is a lifetime condition, can cause so many burden to one and also the family members. The lack of bladder control, it's also another fear, and also the fear, which is like a social one, urine odor. We have social aspect of the quality of life affectation, which include reduction in social interaction, alteration of travel plans. You want to travel, but because of this condition, you are thinking of how to adjust, how to take care of it whenever it comes. We have increased risks of institutionalization also. We also have domestic aspect, which include requirements for specialized underwear, beddings, the all necessary, feeling that it affects one's life. One must think ahead of getting a better underwear, better beddings, more beddings in particular, and also to how to take care of it hygienically. We have also special precautions with clothing. In terms of clothing, after wearing it, whenever this condition is there, that means there's need to change. We'll be adjusting or thinking of how to change their clothes. We have occupational aspects, which include absence from work and also decreased productivity. We have social aspect, we have sexual aspects, which include avoidance of sexual contact and also intimacy. Then there are compounding problems. These problems are problems that lead to silence or either getting inadequate attention or also getting improper investigation. What due to embarrassment, they're feeling embarrassed, so they feel like they should keep quiet. There's no need to talk or express what is happening to them. Time constraint, taking too long to express it, then might lead to inadequate attention. We have knowledge limits because some people think that there's no need to go to the hospital, no need to report that they are having this condition. So it might lead to so many problems. Feeling like because you don't know it, or I feel like it's nothing to express or go to the hospital, it's an issue that one must feel that inadequate attention. And also we have technology limits because if there are limited technologies or tools to use to adequately investigate these conditions, there might be so many compounding problems. Resource limitation also are found on a part of it, which can lead to inadequate access. We have so many types of this urinary incontinence depending on the protocol, which one used to follow, but ideally we have 5 types. We have the stress, the urge, the mix, the overflow, and the functional incontinence. This is telling us a diagram of the three major types: the overflow, the stress, and the urge incontinence, showing the bladder and its effect or action upon each and every one of it. The stress incontinence, this is commonly seen or experienced among females, and it's due because of the weakness of the muscles near the bladder after usually childbirth or menopause. This causes incontinence with coughing, laughing, sneezing, and exercises. That means this incontinence is due to activities that may cause it. The causes include pelvic floor and uterine sphincter weakness, which can be due to pregnancy or childbirth. Pregnancy, the effect of pregnancy can cause this, as there might be so many aspects ranging from hormonal to structural aspects as a result of that pregnancy and childbirth. We have obesity, menopause, and diseases such as Parkinson's disease, multiple sclerosis, and so many medications. Symptoms include leakage with exertion, lifting. If someone is trying to lift something, there might be involuntary leakage or flow of urine. Someone, as they start exercising, they start having that incontinence. As someone is walking, then that incontinence might be there. Even climbing upstairs, as well as sexual intercourse. We have the grades. Grades ranges from 1 to 3. The first one is incontinence with severe stress, such as coughing. If someone is coughing, there might be incontinence, or someone is jogging or sneezing. Then we have the grade 2, which is rapid movement or walking up and down the stairs can lead to that incontinence. We have the third one, which is mild stress. Like, for example, if someone is just standing, that means that person is having the 3rd degree or grade of incontinence. So if we want to assess this physically, we can see with full bladder and stress incontinence, we have the local one, we check the skin, we check for atropic changes, if there's cystocele prolapse, there's bladder neck elevation, to see whether surgery will be benefited or not. We have mental state development anomalies and also neurological examination. Investigations further include the general ones, which include urine investigation. We can go for our routine microscopic culture and sensitivity test to know if there's any infectious or any other conditions affecting it. We'll see the frequency and volume chart or urine diary, which is usually given to the patient to be feeding and then be assessed to know the outcome and income of urine flow and what the person is taking in and out. Then we have the pad test. The subject will be asked to drink 500 cc of water. Then she applied a pre-weighted perineal pad and spent the next hour walking around and series of exercise. Then after that, the pad is weighed. A weight of 1 gram in 1 hour represents an incontinence. We have the basic urodynamics, which include the uroflow, which is the measurement of urine flow rate. The normal is 15 ml per second for void volume of 150 cc. Its value is 1, diagnosis of outflow obstruction, 2, hypertonic dextrosor, and 3, preoperative assessment in patient who is undergoing stress incontinence surgery. And see, he or she is more likely to develop voiding difficulties post-operatively. We have the cystometry, which measures the pressure-volume relationship. By this test, this can be studied due to the following reasons. We have 1, bladder capacity, which is usually 500 to 600 ml. We have the residual urine if it's less than 50 mils. Then the first sensation of urge, 150 to 50 mils, and intravesicular and intra-abdominal pressure also. We have the video cystourethropy, which combines cystometry, uroflowmetry, and radiological screening of the bladder and urethra. This one is actually expensive and time-consuming, but it gives the most accurate information needed to get this diagnosis. We have the ureterocystoscope, which is the inspection of the urethra, the uretrovesicular junction, the bladder walls, and urethral orifices. We observe the amount of residual urine, the bladder capacity, and exclude inflammation, diverticular, and mobility of the uretrovesicular junction in response to rectal squeeze and cough. This is a diagram showing us the normal urethra. This is an incompetent one, which is the second one. And then the sling supports and partially compresses the urethral lumen. The second one is the urge incontinence. Urge incontinence, as the name implies, is when one has the sudden feeling or urge to urinate and can't make it to the toilet fast enough. It is also called an overactive bladder because the muscle in the bladder wall activates when it's not supposed to activate. That it's overactivated. The etiology of this include nerve damage, neurological disease, cancers or tumors, urinary tract infection, constipations in some instances, surgeries, and the use of some drugs such as antidepressant, diuretics, sedatives, and so on. And also unhealthy food or drink habits can also lead to this condition. The symptoms include the frequency, the urgency, and sometimes nocturia. No leakage on position change and increase in intra-abdominal pressure. The next one is the functional incontinence. This type of incontinence happens when someone has a barrier to pee that is not related to their urinary system. That is, there is a problem that does not affect the urinary system, but there is a constriction or constraint to pee in time. It usually occurs in people with disabilities, such as difficulty walking, which may not be able to reach the toilet when they need to pee. For example, the elderly or those having conditions that affect mobility, such as knee osteoarthritis at the chronic stage, giving them time to go to the toilet before reaching there, they start having the incontinence. We have the overflow incontinence, which involves leaking urine after peeing and between trips to the bathroom because the bladder isn't completely empty. This is after peeing. The person might feel that the bladder is not that empty. He or she will start having incontinence immediately after that. This can happen when the muscle in the bladder wall is underactive, so it doesn't activate to squeeze out all the urine. It can also happen when there is blockage between the bladder and the urethra, such as in men, as in enlarged prostate. We have the last but not the least type, which is the mixed incontinence, which sometimes people experience it in their lifetime, which involves mix of one or more of the types of the urinary incontinence, usually the stress and the urge incontinence. We have some clinical manifestation, such as the sensory signs. We have the odor of urine or feces in the room. Whenever someone comes into the room, we'll feel that one. Swelling of the undergarment or bed linings. Irritation of the perineal area because it's always moist, as there is always urine there. Accidents while engaged in physical activity or sneezing or laughing. We have emotional signs, some such as anger. Usually they are angry because they feel like they have something which differentiates them from others. Decline in social activities due to this condition. They feel like they cannot fit into the social life of the world. They feel like, yes, because of this condition, they can't participate or actively in any social gathering or activities, and they have desire for attention. The prevalence rates varies depending on the population one studied, the definition of the urinary incontinence, and how the information is obtained. We have the epidemiology, which is usually underreported. About 40% of women and 10% for men across a range of UK studies shows that. And globally, we have 7.8% prevalence of urinary incontinence among females. The pathophysiology, there is failure of the storage function of the lower urinary tract. We have inappropriate detrital activity and also incompetence of the incontinence maintaining mechanism. In a nutshell, this is just a simple explanation for one to understand what happens. The kidney filters waste product in the body, creating urine to be collected and stored in the bladder. When the bladder is full, it signals the brain to empty the urine through tubes connecting to the bladder. There are muscles that control the opening and closing of the bladder and the tubes that carry the urine away from the bladder into the urethra. The last step is emptying the urine by peeing. People with this incontinence have problem with one of the steps above in the normal processing of urination. We have the general symptoms, which may include suddenly feeling like your bladder is full and you need to pee, leaking urine when you laugh, cough or exercise or have sex, wetting bed sheet or blankets while one is asleep, feeling like you don't empty your bladder after being or dripping or leaking between trips to the toilet. We have risk factors, which ranges from the increasing age. We have obesity, priority or mode of delivery, high impact sports, causes of increase intra-abdominal pressure, chronic cough, family history, urinary tract symptoms, and certain health conditions are among the risk factors. We have the external, which can be divided into the external factors as well as internal factors. For the external ones, we can have the pregnancy and childbirth, we have aging, we have hormone effects, non-obstetric pelvic trauma, and radical surgeries. This include, example, radical hysterectomy, total or complete removal of the uterus. Then we have increased intra-abdominal pressure as well as drug effects. We have the urogenital damages, which include vaginal delivery, aging, estrogen deficiency, neurological diseases, and psychological diseases. For example, aging, gravity, neurologic changing with aging, loss of estrogen, and changes in connective tissue, cross-linking and reducing elasticity. This predisposes one to having incontinence as he or she in particular ages. Pregnancy and childbirth due to hormonal effect in pregnancy, pressures of uterus and contents, the effect of hormones in pregnancy, especially the relaxin, which has more effect on the ligaments and also the ligaments around the pelvic floor, and also leads to laxity of that organs, pelvic floor muscles. The pressure of uterus and its contents due to increase or enlargement of the uterus as the baby grows. The innervation or stretch or crush injury to the pudendal nerve can cause that. Connective tissue changes or injury can cause that, and also mechanical disruption of muscles and sphincter during childbirth. This is a frontal section of the pelvis with the non-pregnant aspect on your left side and the pregnant aspect on the right side at delivery. And we can see there's descent of the baby or crowning of the baby at the pelvis on the right side. The bladder is compressed. There is stretching of the vaginal wall and stretching and tearing of the pubocervical fascia, which is seen there. And also we have compression of the contents of pudendal canal against the pelvic wall. And also we also have stretching and tearing of rectovaginal septum and the stretching of the levator ani muscle, thereby predisposing one to have incontinence as a result of childbirth. We have hormonal effects such as in postmenopausal women due to lack of estrogen and urethral coaptation affected by the loss of estrogen. Increased intra-abdominal pressure can be due to so many aspects such as pulmonary diseases, constipation, or straining. Lifting exercises ascites, that is abnormal increase in the abdominal pressure, and hepatomegaly, that is the increase of the liver organs, and also obesity can predispose one to have this condition. Drugs such as alpha blocking agents like tyrosine, prazosin, phenoxybenzamine, phenothiazine, methyl-dopa, benzodiazepines are also predisposing one to this condition. The evaluation or diagnosis of this condition and what are the aims of diagnosing it, to rule out any reversible factors and to determine the type and treatment, and also determine the referral history, to know the medical condition and how to address it, medical history, then questionnaires to be administered in which the subject can answer, then to guide one on the best diagnosis, and then further management of the condition. We have the bladder diary physical assessment or examination. We have the pelvic floor examination. We have the cough stress test, as well as the digital rectal examination for the men. For the diagnostic evaluation, we can have urinalysis and urine culture. We check for if there's any problem with the urine. We check for culture to see if there's any bacterial or any microbial involvement. It's usually you need urine measurement to know if to know or to guide on what type and how to manage it. Urodynamic studies, serum electrolytes, calcium levels are also important. If there is need, you can go for spinal MRI and also ultrasonography, cystourethropy, intravenous pyelography to go, that will guide one to see from the contrast taken up to the excretion of the contrast if there is any blockage there. Fluoroscopy and video urodynamics, uroflowmetry, cystometry, and urethral pressure profilometry. We have electromyography to guide on the electrical activity of the muscles there. We have the history taken. History taken involves proper history from the onset to the reason for the referral and history of past medical condition, any family history which genetics plays a role in this condition, any history of fall trauma or any involvement of any accident concerning the urinary tract system. Then we go for the physical examination, we go for urinalysis, and then we can get the patient's verbal response if indicated. If there's any symptoms of incomplete emptying, long-standing diabetes mellitus, history of urinary retention, failure of pharmacological therapy, or pelvic floor prolapse, as well as previous incontinence surgery being given. Focus on medical, neurological, genitourinary history. We review voiding patterns by seeing taking the fluid, what fluid is taken, and the duration of the fluid intake, what type of fluid is taken, and then taking the output of the fluid. Voiding diary is necessary, which is given for one to record the voiding time and review medication if there is need for treatment and also non-treatment. Explore symptoms such as the duration, the most bothersome one, frequency, and what precipitated the symptoms. Assess mental states and mobility. This is an example of daily bladder diary, which indicates what one is taking, the quantity taken, the number of times taken, the amount one take, and then the leakage. How much in amount does one leak? Does one feel a strong urge to go to the toilet or not? What was one doing when that person have an incontinence? This bladder diary helps to show the causes of bladder control trouble. This sample shows you how to use the diary with the date and name on the right side of it, then the timing on the left side along the columns. And then along the rows, we have the timing from the sample taken and the timing. Timing ranges from hourly 6 to 7, 7 to 8, up to each an hour. You write whatever you take. For example, what do you take? If it's a drink, what type of drink? This is water. How much? 1, 2 cups. How many times? So time, like from within an hour. If taking the water 1 cup 10 or 15 times, then how much do you fill in the amount? Small amount, medium or large amount? Then the accidental leaks, what happened? For how much do you leak? Is it large that just came out, or no, it's just a small one? How did you feel the urge? Is it that you just saw it there spilling, or you just realized that you are having that urge to urinate, or it just came in with a mixed type, coming in with the urge and then having it? What are you doing, or what triggers it? Do you sneeze, exercise, lifting, laughing, or doing any activity? This diary will guide one to know the type of incontinence and the treatment to be rendered. The purpose of this is to assess severity, determine precipitating events, and identify fluid intake patterns, as well as identifying voiding patterns. This is just telling us an example. If you have a voiding diary, you can just write it. Voiding interval, just fill it and know. If one uses it in the hospital or clinic, it will guide you on the management of condition. We have the children assessment. Sometimes children do present with incontinence, and not bedwetting rather, but incontinence. So we evaluate the child well to know that it's actually an incontinence. Prior evaluation, we have to exclude structural changes that might occur. Current urinary tract infection can predispose children to have incontinence also. Upper tract pathology, neurological findings should be examined. Okay, physical findings like checking the spine, the abdomen, the gait, the reflexes, and the genitalia are also relevant. Check the kidneys, make sure they're okay. Go for an ultrasound to see the urethra, the bladder, the spine, and the guts. Ultrasound can be. Uroflowmetry too can also be good, and also urine analysis. For the adult assessment, we can have some symptoms: the frequency, nocturia, dysuria, incomplete emptying, incontinence, urgency, the current infection, and the dyspareunia. Then we have prolapse. So for the physical examination, you can have the general examination. First, to check if there is any edema, neurologic abnormalities, any mobility problem, any cognitive disorder, and any dexterity problem. We check the abdomen if there is any increased abdominal pressure, if there's any inflammation of the internal abdominal organs, or if there's any problem that can be palpated and checked. And for the abdomen, we can also go for an ultrasound scan to see the internal organs and know if there is any problem. For the pelvic and rectal examination can also be done in women. And for the men, it can be only rectal examination, which is usually digital rectal examination. Examination of the back and the lower limbs are necessary to screen out if there is any underlying condition that is causing it. Then observe urine loss with cough. Urinalysis, condition associated with overactive bladder. We can have hematuria, pyuria, bacteriuria, glossariuria, proteinuria, and also leads to overactive bladder. And also we go for the urine culture to see if there's any microscopic organ responsible for it. We have the post-void residual, which is usually, if clinically indicated, it can be done by catheterization or ultrasound. If we have less than 5 ml, it's considered adequate. Repetitive post-void residual of greater than 200 ml is considered inadequate. Use clinical judgment when interpreting the result in the intermediate range. We have the pelvic and vaginal screening to check if there's any atrophy, if the skin condition is normal, if there's coughing, if there's perineal descent, mucosal condition can be checked via pelvic examination. Then we check for prolapse, if there's any prolapse, and we then check for the strength of the pelvic muscles. We have initial investigations, urinalysis, residual urine test, prostate-specific antigen is also necessary in men to know if there is involvement of the prostate gland or if there is inflammation of the prostate. Final test, cystoscope, urodynamics can be used. These are some tips that can be helpful to keep that can be helpful for anyone that is experiencing this kind of condition. You have to keep a journal or a notebook, then it will serve as your voiding diary to detect if it's a normal voiding or abnormal. How many time do you urinate? How much urine are you leaking? Is it enough to require the use of a pad or a diaper? How many times of the day do you notice the urine leakage? How much water, alcohol, or caffeine one is consuming? Which medication are you taking? Do you feel a sudden urge to urinate before you have a leak? Do you notice wet bed sheets caused by leaking overnight? Does it feel like you don't empty your bladder after you pee? Do you leak urine when you sneeze, cough, bend over, or exercise? Do you leak between trips to the toilet? Your doctor will use the answer to the questions listed above and check your body during a physical examination to know if something is causing this urinary incontinence. In male, female, it can be due to pelvic organ, pelvic muscle involvement, or prostate in male. Other tests are necessary for the diagnosis, which ranges from simple tests to complex one. Then we have the visual inspection, external dermatome check to check the dermatome around the place. Cough, we have the pelvic floor muscle check to check it if there is any problem. Internal check includes sensation, muscle bulk, vaginal tissue quality, prolapse, cough reflex, and also the pelvic muscle contraction, deep and superficial. We check for trigger points and also for scars. We have the pelvic muscles assessment, which involves assessment of the power, the endurance, which we call the perfect means of assessing it, the repetition, the fastness, the elevation or post-vaginal wall, and the co-contraction of the transversus abdominal muscle, then the timing of the nerve. The power, we have a measure of 0 to 5 using the modified Oxford grading system. So it's the contraction. If there's no contraction, it's term 0. A flicker signifies 1, weak signifies 2, 3 means moderate and involves deep pelvic muscle muscle contraction. We have the moderate one, strong with resistance, and the strong one, which is the 5th one. We have endurance, how long a patient is able to sustain 50 to 100% contraction up to 10 seconds. We have repetition, number of endurance holds achieved up to 10. We have the first number of short, powerful contraction up to 10, co-contraction, gentle contraction of the transversus abdominis and the neck, able to sustain a pelvic floor muscle contraction during a cough. We have the differential diagnosis to check all reversible causes and other types of incontinence and the neurological and anatomical abnormalities. These are the delirium, that's the diaper. We have delirium, infection, the reversible causes of this condition. Atrophic vaginitis or urethritis, pharmaceuticals, psychological disorder, endocrine disorders, restricted mobility, and stool impaction. We have red flags. Red flags for this condition include urinary tract infections, difficulty with bladder emptying, urethral or bladder pain, constant leakage, hematuria, urogenital malignancy, or post-void residual volume. Outcome measures include, we have so many outcome measures, but these are few. Even the voiding diary can also serve as one, and as well as the PAD test. We have patient-reported outcome measure. We have international consultation of incontinence questionnaire. We have Michigan Incontinence Symptoms Index, as well as urogenital distress inventory. In conclusion, urinary incontinence can have a significant adverse effect on the quality of life of the sufferer. Therefore, patient's perspective of symptoms and the impact on patients are needed in the plan of management, treatment, and evaluation of treatment outcome to ensure maximum benefit of interventions. Thank you.
Thank you. If there is any question or contribution, you can ask. any question or contribution?
Thank you. We are still waiting for questions. Today, the house is silent. We need questions. This is women health. Questions, not only questions, we can even entertain comments, additions, contributions. Hello? Okay, thank you so much. In the absence of any person, we want to sincerely thank our first resource person for doing justice to the section and finished on time. I think we can have the next presentation, or we can have some break. What do you think? Do we have some 15-minute break? Or we just continue with the second session, the treatment? What are your opinions? Okay. We continue, right? We are still not yet tired yet.
Yes, continue. Before network will start misbehaving now.
Okay. Okay. Yeah, I think the second presenter is also with us. So just give few minutes for her to set up so that she can begin. Thank you.
No be your fault now. Shebi you don't almost come out. If you talk now. That return to pool is compulsory for you if you have not been paying it. You pay it in your final year. And they don't want to know whether you have spent, whether you were given scholarship for 3 years or 4 years.
If it's 3 years, you pay for only 3 years. If it's 2 years, you pay for only 2 years. If it's 1 year, you pay for
like you now pay 5 years.
Then it's 5 years I'll pay.
How is mommy? And how are you feeling now?
I'm sure she's feeling fine.
Yeah, sorry, we'll be starting in 15-minute time.
Can't hear. Oh. Has the workshop started again?
Yes, we are about to start.
Okay, I'm not hearing voice. Okay, thank you.
Yes. Good morning to you all.
Good morning, ma.
Yes. I'm Rukaya Ibrahim Hassan. I'm presenting on. Are you seeing the screen?
Yes.
Yes, ma.
Okay, so I'm presenting on physiotherapy management of urinary incontinence. These are the synopses. So, as the previous presenter highlighted, she already talked to you about what urinary incontinence is. So, the management is to prevent urinary incontinence is a prevalent condition, and it affects women worldwide. So the aim of physiotherapy is to normalize pelvic floor muscle strength and coordination, improve tone, voluntary control, inhibit overactive detrusor, normalize normal number of micturations per day, reduce frequency and urgency, increase bladder capacity and volume at first desire to void. So all these things can be achieved through pelvic floor muscle training, behavioral therapy, and bladder training. So for the pelvic floor muscle training, it is recommended as the first line of treatment for most common forms of incontinence. And there are so many researches that have been carried out to show its effect on urinary incontinence. And a Cochrane review also found out that women who underwent pelvic floor muscle training are 8 times more likely to improve or have cure of incontinence than those who did not perform in any exercise. So it can be carried out with or without biofeedback. So the pelvic floor muscle training has a protocol or a way it can be administered. The stage one, it has 2 stages. The stage one is for you to teach the patient how to search or find the muscles, how to locate the muscle. Then you now educate on, you teach the patient the anatomy, the physiology, and the function of the pelvic floor muscle, and how the exercises you prescribe can prevent or treat urinary incontinence. Then the woman tries to contract the pelvic floor muscle while the physiotherapy observe the perineum. You will now open the patient, observe, and ask the patient to contract the pelvic floor muscles. Then if you now do that, if you observe any contraction, or even if you did not observe, then you now insert one finger at the lower third of the vagina, and ask the patient to squeeze and lift around the finger. Then if you feel that squeeze or lift around the finger, that means the patient is performing is good, the contraction is good. Then you now be able to explain the patient what you are trying to do. So if the patient can correctly contract the vagina, and you now feel she can contract and relax, and you feel the activity with your finger, then you now assess the muscle strength and the endurance. I don't know. I'm not in the first part of the presentation, sorry. So will be I know maybe she has taught you about the perfect way of doing the assessment, or all how to do muscle to assess the endurance and strength of the pelvic floor muscle. So if you are taught, we can go forward. Can we go forward if you are conversant with the way you assess the strength and endurance?
Please, my one now recap it. You can say recap it and remind us.
Okay.
Yeah.
So usually there are a lot of way, but the most common type is the using of perfect acronym. The perfect, the P is for power, E for endurance, R for repetition, F for fast contraction. Then the ECT is every contraction timed. So for the power, you assess the using the modified Oxford grading system. It has 0 to 5, with 0 no contraction and 5 good contraction with excellent lift. Then for the E, which is the endurance, mind you, the P is for strength. How you do it, you just ask the patient to do maximum voluntary contraction, which die your finger inside. Then you will be able to notice if you are good with the modified Oxford grading. Then you will feel how strength the muscle is. Then the E for endurance is the number. You now ask the patient to do that one maximum voluntary contraction. The first one for strength, you know is just the 0, 1, 2, 3, 4, 5 that you now mark. Then for the endurance, after when your finger is there, you now ask the patient to maximally contract. Then you feel if there is any let go, or if she can maximally contract without any let go. That means she has a good endurance. Then for the R, repetition, then that contraction, you now ask her to repeat it. That maximum voluntary contraction, you ask the patient to repeat it. Like say she can contract and hold, then you now count the seconds that she can hold. Maybe the patient is able to hold for 3 seconds, 5 seconds, or 10 seconds at the endurance stage. Then at the repetition, her ability to repeat this contraction, contract for 3 seconds, relax for 3 seconds, and repeat it for like the number of times that you feel the muscle is fatigued. So it can reach like 7, 8, or 9. At times, some women cannot do that. So if you now count, then you now record. Then for the fast contraction, then the ability of the patient to contract maximally and relax fully without you counting the number of times she now hold. Don't count, just as fast as she can contract and relax. So she can be able to do it like say 7, 10, but as fast as possible. That is the fast. The If a patient has a power of let's say 3 and endurance, she can be able to hold that contraction maximally for 5 seconds. Then she can now maybe repeat the contraction with contract 3 seconds, relax 3 seconds. The number of relaxation and contraction should be equal. That is R for like 4 seconds or 5 or 6. Then the F is how fast she can do the contraction and relax without you timing it. That's how it is being done. Then the ECT, every contraction time, that one you use biofeedback machine to assess that one. So are we clear? Can we go forward?
Yes, ma'am.
Yes. So if the patient can do this contraction and relaxation, but if the patient is on, if she can do it, that means we have now measured it. Then if she cannot do it, there is no palpable contraction or straining. The patient is asked to try to contract at home. Then for that week, you cannot treat the patient, just teach her how to do contraction and relaxation at home. Then you can incorporate it using Paula technique. The Paula technique is just the Paula said all the round muscles in the body are connected to each other. So if you now, the round muscles are the muscles of the eye and the mouth and the hypotenuse eminence of the hand. So if you now close your eyes, contract your eye, or close your eye maximally and contract your mouth maximally, you feel the contraction on your perineal muscles. So if you can do that, if you can teach the patient and the patient feels the contraction and the perineum aspect, then she should now go home and be repeating that using the eye closure and the mouth closure. But if she still cannot feel, then you now advise her to stop the dribbling urine at the end of bathing. So for the whole of the first week, that's how she will be doing, so that she will now get used to the contraction of the pelvic floor muscle. And if the patient came back and she still cannot do that, then you now facilitate the contraction using either perineal massage or electrical stimulation. So the electric stimulation in this aspect of patients is just for the patient to have awareness of how to contract and relax the pelvic floor muscles. Then when the second part of the protocol for pelvic floor muscle training is the strength training. Then now the patient can now perform is aware. She has now searched the muscles, learn how to do the contraction, and can now control. She can contract and relax. This is what the first stage is all about. So if the patient is aware of all these things, then you now go to stage 2. That is the stage whereby you now prescribe the exercises. Strong verbal encouragement to motivate for effort of maximum voluntary contraction is advised. So the therapist must always encourage maximum voluntary contraction. Then for strength, like I said, the patient should perform maximum voluntary contraction. Why I now use this red is the second should not be more than 10. If you ask the patient to contract and she has a very good contraction, so the muscle should not be allowed to go into fatigue. So you now start, let's say the patient can now do this maximum voluntary contraction of 5 seconds. So if you now ask her to squeeze the pelvic floor with your hand inside, you feel it. You now start counting 1, 2, 3, 4, 5, and at when it's now get to 5, you now feel a let go. So take 50 to 70% of this 5, which is around 3. That means the patient will now be doing maximum voluntary contraction 3 times for 3 seconds, and should be followed by a similar period of 3 seconds. Then this should be repeated. The maximum she will be doing is 10 to 15 times per session. But if you now feel that she can do this contraction, like I said, 3 seconds, so you need to be progressing the exercise. Then you start giving her to do like 5 times per session with a 3 to 5 sessions daily. That means she will do it, she will contract maximally and for 3 seconds, relax for 3 seconds, do it again for 5 times, then for 3 to 5 times daily. Do we understand?
No, please.
Yes. So for the endurance, she will perform quick repeated maximum voluntary contraction of the pelvic floor muscle while maintaining a normal breathing rate and keeping accessory muscles relaxed. The accessory muscles are the muscles of the thigh, gluteus, abdomen, and the rest. Then instead of, you see, this is 15 to 20 repetition per set. She will do one set every day, and she will now start maybe from 5. Then as she is improving every week, can now be increasing the number of repetitions per set, but it should not exceed 15 to 20 repetition per set every day. And she would do these exercises for maximum of 8 weeks every day and up to 6 months. If there is no improvement, that means something is, maybe she is not doing the correct exercise, or there is another thing that happens in the pelvic floor muscles. So studies have suggested that supervised pelvic floor muscle training is more effective than unsupervised, particularly in the initial stage. Yes. Then the functional pelvic floor muscle training. This incorporates a correct pelvic floor muscle contraction into activities of daily living. This is about is that when a patient is trying to lift or transfer out of bed, sneeze, laugh, and the rest, she has to perform maximum voluntary contraction. That means the patient has to be aware of all her activities so that she will not be increasing strength to the pelvic floor muscle. If there is increase in intra-abdominal pressure, the muscle will now, instead of the muscle to be strong, it will now be weakening again. So functional pelvic floor muscle strength has to be incorporated in the exercises. Studies also shows that co-contraction of the pelvic floor muscles via contraction of other muscles, strengthening training of back, abdominal muscles, neck, and relaxation breathing exercise have a potential for training effect of. What this statement is saying is that you can now incorporate pelvic floor muscle training with either um, with core strengthening exercises like the bridging exercise, the clamshell exercises, all the core strengthening exercises, so the core contraction of this muscle, the transverse abdominis and the rest, the gluteus muscle and the rest, the core contraction of the muscles will now increase the pelvic floor muscle strength. Then, like I said earlier, pelvic floor muscle is effective with or without biofeedback. So there are researches that have shown that even without biofeedback, pelvic floor muscle, if performed correctly, will help in strengthening the pelvic floor muscle exercise. And there are other studies that shown that pelvic floor muscle, when performed with biofeedback, have shown to improve outcomes of pelvic floor muscle by helping the patient optimize their muscle contraction. It allows women to see almost instantly their muscle activities during the exercise. The biofeedback is just a technique that uses visual or auditory feedback to help the patient identify and properly contract the pelvic floor muscle. It is administered via vaginal or rectal sensors that detect muscle activity. It is especially useful for patients who have difficulty recognizing the correct muscle group. So this statement is saying that is in line with what I have said earlier. And biofeedback treatment uses one machine. I had wanted to show you the machine, but this I have issue yesterday. My system got corrupted. I had to do another slides. So all these slides that don't have any image that will carry you along. Sorry for that. And effectiveness of the pelvic floor muscle training. The pelvic floor muscle training, when performed correctly, will lead to lift of the pelvic floor to a higher anatomical location inside the pelvis. It increases the cross-sectional area of the muscle, that means it hypertrophies the muscles. It increases stiffness of the connective tissue within and around the pelvic floor muscle, and reduction of levator ani hiatus area. The levator hiatus is the opening of the vagina. So when the patient is doing correct pelvic floor muscle training, the area can reduce. And the second treatment is behavioral therapy. Behavioral therapy incorporates lifestyle modification, weight loss, and postural training. The lifestyle modifications include fluid management, thereby reducing bladder irritants such as caffeine, alcohol, carbonated drinks. Decreasing the amount of these drinks will now decrease the urinary frequency and urgency. Then the time voiding by the use of bladder diary. The bladder diary, most of the times if you go online you will see a lot of it, but they are so cumbersome. So you can just design your own that suit the environment you are. Like myself, I design one with just days of the week and the time from 5 a.m. to 4 a.m. Then every I don't take account I did not take into account the amount of fluid and bread that the patient will be taking, because majority of my patient will not understand and they don't measure the amount of water they took or fluid. So you need to just improvise your own that suit the environment you are. What I'm always interested in is the accidents, number of times that she now soil her clothes before going to toilet. So how I used to do it is I will now ask the patient to be going to toilet every 2 or 3 hours, depending on how severe the urinary incontinence the patient has. So if she cannot hold urine for 2 hours, you start every hour, but that is stressing, especially at night. So you just have to just take the patient into consideration. But for every 2 to 3 hours, the patient, whether she feels she wants to urinate or not, should just go to toilet. That will prevent accidents. Then weight loss. Obesity increases intra-abdominal pressure and worsen incontinence, and studies have shown that weight loss, particularly in obese women, can significantly improve urinary symptoms. And postural training. Correcting poor posture helps reduce intra-abdominal pressure, which in turn helps relieve stress on the pelvic floor muscle. So educating patients on optimal posture during daily activities can prevent symptoms aggravation. And the third is the bladder training, which is often used to manage urge incontinence by teaching the bladder to hold urine for longer periods. The goal is to increase the time between urinations and reduce urgency. The patients are taught to delay urine by small increment each day. And you now teach techniques of distraction. Um, these techniques of distraction are performed with deep breathing and mental exercise. How it's been done is that you now teach the patient, the moment the patient feels that urge to go to toilet, she should now distract her thinking. This is the mental exercise. Or she should start with the breathing exercise. The moment she feels that urge to go to toilet, she should just start doing breathing exercise, deep breathing and fast. She should take inhale air with the nose and exhale with the mouth, as and she should be doing it. The patient should do it as fast as possible. Then she will now distract her thinking. That's the mental exercise. Instead of the patient to start rushing and going to toilet, she should just distract herself and start thinking of something that amuse the patient. Like how I used to tell my patient is that I like eating chicken. So anytime I have that urge, then she should just distract herself and start thinking like I myself used to do it. I will just start thinking of me eating one beautiful chicken with the deep breathing exercise. So this distraction will now take the signals from the bladder, and the that pounding urge will now subside. So the moment the urge subsided, then the now patient will now take herself to toilet. But at the first instant, this technique is very difficult because for somebody to start with the deep breathing exercise and the mental exercise, you see, if you are not used to it, you cannot do it at the first instant. Urine will leak. But if the patient is conversant with it, urine will stop leaking. And the moment that signal subsided, that person should just take him or herself to toilet. So Wallace et al. Found this bladder training to improve continence and quality of life, particularly when combined with pelvic floor muscle training. Then the use of vaginal cons or weights. I know most of us are all conversant with how it comes. It comes with small weights, and it is used as a resistance exercise to enhance the strengthening of the muscles. So it's a progressive resistance training with weight, and it has shown to improve stress urinary incontinence in women, in some women, but it also works in urge incontinence. It's just that it's more in stress incontinence. So the patient will now insert a small weighted cone into the vagina and perform this exercise, the Kegel exercise, the strengthening or endurance with the cone inside. So by contracting the pelvic floor muscles. So I had wanted to talk a lot about electrotherapy modalities, but all the modalities have been found. It's not that they did not work, but there is not any evidence to support the use of all the electrical modalities. But some of the literature said that electrical stimulation works in strengthening, as I said earlier, and hypertrophy of the muscle. But there are so many of the literatures that now said that if a patient is used to using the electrical stimulation, she cannot do the pelvic floor muscle training by herself, and it will now lead to overuse and um, hypertonia of the muscle. Then there is this posterior tibial nerve stimulation, which was found to reduce the urge incontinence. But also, even at that one, there were no researches to support the evidence. All the evidences are weak in electrotherapy, but they can be incorporated. So for urge incontinence, the pelvic floor muscle training helps provide better bladder control and reduce urgency symptoms. I have explained how the biofeedback and the vaginal cons are being used. We also talked about the bladder training, the schedule voiding, the delay techniques, and the fluid management. We talked about the behavioral therapy. So in the behavioral therapy for urge incontinence, you will ask the patient to avoid spicy foods and citrus drinks, because this irritates the pelvic floor, the bladder as well. So for electrical muscle stimulation, the only research that I found that talked about it is that for urge incontinence, slow twitch mechanism is used to it affect the detrusor inhibition reflex by normalizing it, thus preventing unwanted bladder control. These are the parameters you can use. The 5 to 10 hertz, that means you use low frequency and high amplitude, and you now give patient this twice a week. Though it's just one, I think, or two studies that documented this. And even the parameters, some are saying that high frequency, um, low amplitude will be good for urge, and there are lots of debates. So that is why I didn't even bother myself to put so many on the electrical stimulation aspect. And the relaxation technique in urge incontinence. So you now teach patient how to do stretch management and whole body relaxation technique. This helps in reducing stress, and stress exacerbates bladder overactivity. So these exercises diaphragmatic breathing, and yoga and meditation too. They are said to help reduce stress and promote bladder control. Then the vaginal pessary and vaginal support. These may be used to provide additional, these are all adjuncts, but the major ones are the pelvic floor training, and the bladder and behavioral therapy. So these are the adjuncts to treatment. The vaginal pessaries, when inserted or support, may be used to provide additional bladder and urethral support for some patients with combined incontinence. Then for stress urinary incontinence, it is documented that pelvic floor muscle training strengthens the pelvic floor muscle. It helps to support the bladder and urethra, reducing urine leakage during activities that increases abdominal pressure. Then under stress urinary incontinence, the difference between stress and urinary, for stress and urge. For urge, we talked about this distraction. Then while for stress, you do functional pelvic floor muscle training, which is also known as neck maneuver. That is the moment you are about to sneeze, the patient is about to sneeze, cough, laugh, or something like, or in anything that increases intra-abdominal pressure, the patient should now quickly contract the pelvic floor muscle so that it will not become weak again. Then the biofeedback and the use of vaginal cons. So for electrical stimulation, the the researches that I found, like in urge, they uses fast twitch mechanism. It is used in promoting strength and hypertrophy of the pelvic floor muscle. So the parameters, as you can see, this one uses parameter of 35 to 40 frequency. That means high frequency, low amplitude, and that of urge is 5 to 10, and the amplitude is 4. These are the difference. This one is for twitch, fast, and for urge is low. And the behavioral therapy too is essential in reducing intra-abdominal pressure. So weight management, as in urge and fluid intake management, but the major thing in um, stress urinary training is smoking cessation, because it is found out that smoking also increases stress and increases intra-abdominal pressure. Um, yes, so patients should quit smoking and should incorporate exercises that do not put excessive pressure to pelvic floor, such as swimming, walking instead of running, jumping, and rest. All this running, jogging, and rest, put heavy lifting and rest, increases intra-abdominal pressure, and at, in turn weakens the muscles, and opens the urethra and increases stress urinary incontinence. Then the core muscle training in stress urinary incontinence, they are carried out to strengthen the core muscles. These core muscles are the abdominal muscles, the back muscles, and the diaphragm. They are said to improve pelvic stability and enhances the function of the pelvic floor. Proper posture also maximizes stress on the pelvic floor muscles. Then the deep these exercises are the deep abdominal activation. That is the transverse abdominis activation. How you do it is, you now locate your anterior superior iliac spine, use two of your fingers, and you now locate it. Then you now come forward as if to the middle near your umbilicus, just below the umbilicus. That is where the deep the transverse abdominis are located. So that is, you now ask the patient to contract these muscles as if the umbilicus will now touch the spine. So if you do it correctly, this muscle, your hands will now come approximate as if they will touch each other. Then the postural awareness, train patient to maintain optimal posture to reduce intra-abdominal pressure, and integration of these exercises and pelvic encourage pelvic floor and core activation during tasks like lifting, as I said earlier. Anything that means, this is telling us that anything that we are doing, we have to be mindful about our pelvic floor muscles. If you want to laugh, lift, cough, or any sneeze, you have to contract your pelvic floor muscle so as not to increase its weakness. Then diaphragmatic breathing and relaxation helps patient to coordinate the pelvic floor and abdominal muscles, reducing leakage during exertion. Key to success. Progressive exercise regimen. What this is saying is, like I said earlier, if a patient can contract the pelvic floor muscle in strength training for 3 seconds, so after a week you now increase it to 5, or you now assess again. If you assess, then you'll be able to say has improved, or the patient has not improved. If the patient improves, she can now maximally voluntarily contract the pelvic floor muscle instead of 5 before, maybe to 7. Then if she can do it to 7, we now take 50 to 70% of 7, which is like 5. Then that means you have progressed the exercise regimen. Likewise, that of the endurance. And the motivation and compliance. Encourage patient adherence through clear goal setting. That is why education is very, very important in treating all pelvic floor muscle dysfunctions. If you encourage your patient, explain the procedure, what you're about doing, because most patients will just be thinking, how will you just be telling me to just contract and relax? If you didn't tell the patient the benefit of all these exercises, the patient may end up not complying, and at the end of the day, that is why most of our patients, if we are not careful, they will just opt for surgery, which at the end of the day will now still make the muscles to become weaker. Long-term maintenance. Physiotherapy not only aims at immediate improvement, but also emphasize long-term maintenance of pelvic floor muscle strength to prevent reoccurrence. So, as I said earlier, you maintain you, you maintain we are not only after immediate improvement of the patient, so you plan for a longer time, even after, if you maybe the patient is now continent enough and you feel you want to discharge the patient, you will now tell the patient, like I used to say to my patient, that even if I discharge you, you must continue with your contract and relax anytime. If you are doing anything, just remember to be contracting and relaxing the pelvic floor muscles. So if you do that, that means you will maintain for a long time, and the patient will not come back after maybe 1 or 2 years. Then barriers to success. Normally, women with urinary incontinence will receive physiotherapy once a week for a period of 4 to 8 weeks. So this, in fact, so many literatures are saying that this is the ideal way, the way we used to do it. But so many literatures will now have said that effect will start in after 8 weeks. So that means you treat your patient to three for between 3 to 6 months if you want complete management or cure. Instruction and performance of pelvic floor muscle exercise at home are supplemented by physiotherapy management. So even if we want to supplement and do the correct pelvic floor muscle exercise, we have to be asking the patient to do it, and this is how should be doing it at home. If we cannot do this, give instruction and the performance and all these things at home, that means the patient cannot, this once a week, um, appointment will not will not make the patient to have continence again. Adherence to physiotherapy treatment when accompanied by prescribed exercise is likely to be successful for strength urinary incontinence. Not only stress all the incontinence, adherence to treatment will give excellent outcome. So such factors such as education, activity level. That is what I said. If you did not educate your patient well on what she is having and what she is expected to do and the rest, the patient will not get better. Then activity level. If a patient is a stressful person, that means um, her outcome to treatment will hinder. The parity multiparous patients have been found to have mostly found to have weak, or let's say pelvic floor muscle dysfunctions. So their own is severe, and at times if care is not taken, patient has to undergo surgery before physiotherapy. Patient should quit smoking, and if patient has any pelvic pain, it also affects the ability to correctly perform the pelvic floor muscles. Then prevention. Generally, there is no there is no study that has been found to apply pelvic floor muscle training for primary prevention of incontinence. So most of the studies that I found, I saw on talking about pregnancy and postpartum women. But theoretically, it is estimated that strengthening the pelvic floor muscle by specific training will have the potential to prevent urinary incontinence and pelvic organ prolapse. Strength training may increase the pelvic floor volume and lift the levator plate to a more cranial level inside the pelvis. The few studies published on the prevention have concentrated on training during pregnancy or childhood, like I said earlier. Conclusion: Physiotherapy offers a non-effective approach to managing urinary incontinence by strengthening the pelvic floor, promoting healthy bladder habits, and tailoring treatment to each individual. Patients will regain control and improve quality of life. So, recommendations: there is need for research on how to motivate the female population to increase their general physical activity level and especially exercise for pelvic floor muscle. More research should also investigate the barriers for including pelvic floor muscle training as a natural part of strength training programs for women in fitness centers and exercise classes. Here are my references. Thank you for listening. Are you with me? Question, comment, and contribution?
Assalamu alaikum. Thank you so much, Dr. Rakaya, for the presentation. It's really a good one.
Thank you, Dr.
Yes,
Sarah.
please. Yes, please. Can you shed more light regarding the effectiveness of electrical stimulation in urinary incontinence? Does that mean incorporating the electrical stimulation is inappropriate, or what do you mean, please? Thank you.
Okay. It's not that way is inappropriate. It's just that you cannot use it as a sole like pelvic floor muscle training as a standalone. But so many researchers have found that pelvic floor muscle training can stand alone in the treatment, either with the adjunct or without the adjunct. So the majority of the researches that I went through, and in fact, even I use electrical stimulation as just an awareness, to give awareness to patient. If the patient cannot perform the pelvic floor muscle training, or she is not aware, you see, because so many of the patients at first visit, they don't know how to even locate the pelvic floor muscles. So you use electrical stimulation to give them awareness. But as a standalone, you cannot use it. Thank you.
Thank you, thank you.
I hope this.
Thank you so much. So the reason for my question is because you related it with some researches that there is still debate regarding the use of electrical stimulation. Yes, from the little
Yes.
knowledge that I have, it's just a contribution. But the little knowledge that I have, incorporating the electrical stimulation is good when the patient's power is just 1 to 2, just because the
Yes.
way you explain it, because of the awareness. Yes, because of the awareness.
Yes.
However, you
Yes.
can continue using the electrical stimulation as an adjunct with other management. You can continue
Yes.
it because it gives more sensation to the pelvic floor muscle in addition to other exercises. Thank you so much. Because there are researches that there
Debatable.
is a review also that supports its use. Yes. Thank you
Yes,
so much.
it's still debatable. So because there are researches in pelvic floor muscle dysfunction without urinary incontinence, that is when you can use it for that. But in in urinary incontinence, that is where the question mark is mostly.
Oh, good
Okay, thank
afternoon.
you so much.
Mm.
Uh, Good afternoon, please, and thank
Good
you, Dr.
afternoon, sir.
Aya, for a very beautiful presentation.
Thank you,
Uh,
sir.
I'm also having um, some concerns regarding the electrotherapy. So I don't
Yes.
know, is it, in other words, we are saying it's still relevant or still irrelevant? Okay, it doesn't necessarily matter if we use electrotherapy or not, right?
Yes.
All right. Thank you very much.
Yes. Thank you, sir. Question, comment, or contribution?
Okay, good afternoon.
Good afternoon, sir.
Thank you so much for the presentation.
Yeah,
So,
thank you, sir.
as I was following,
Yes, sir.
at a point, I think you were talking about urge incontinence, if I got that right, where you were talking about the behavioral modification, like
Yes.
distraction therapy.
Yes, yes, sir.
So, I wanted to find out, does it have a duration to it? I mean, a duration for the distraction before the individual goes to void.
Sir, there is no duration. The moment, what the distraction technique is all about is the moment the patient start feeling that urge that cannot, you know how the urge is. You cannot even said, let me wait till I got to toilet before you start leaking urine. That's how urge incontinence is. The moment you feel that urge, urine will just start leaking. So the moment the patient start feeling that urge to urinate, she should now start the breathing exercise as fast as possible. Then the mental exercise by distracting the attention, the patient mindset to something else. So when you now do the distraction, the impulse that is going to the bladder will now subside. So the moment it subsides, the patient should now just that person should just take him or herself to toilet and urinate, because when what is saying is that there is so many literatures that even said if you did not take yourself immediately after the distraction technique to the toilet, the next signal that will come, it will now be more than the previous one. So that means urine will now leak. You understand, sir?
Yes, I do, man.
Yes,
Thank
so
you so
that
much.
is the essence of the
It's clear
distraction
now.
technique. Yes, sir.
Hello, ma'am.
Yes, sir.
Thank you for your presentation, ma'am. I do have a question.
Okay, sir.
I'm following your slide. You said there are some, or we should educate the patients on postures that would decrease or reduce abdominal pressure.
Yes, sir.
But we didn't really pinpoint or like mention or give examples of these positions to or that reduces intra-abdominal pressure. I don't know if you could help us with that, ma'am.
Yes, sir. Um, what is saying is that if somebody is, let's take for example, maybe your work activity is always has to do with standing. So what he's saying is that you minimize the standing, because you see if you are doing standing a lot, the abdominal pressure will be much. Then maybe squatting exercise. If you are doing squatting, running, jumping, and the rest will increase intra-abdominal pressure. So anything like lifting too, and the rest. So this is what we mean. Are you clear?
Okay, ma'am. All right,
Yes.
ma'am. Thank you, ma'am.
Yes.
Good afternoon, ma'am.
Good afternoon, ma.
Thank you so much for this very enriching
Because it just reminds me
presentation.
that my movement must be very
Please, I want to
clear. So
find
by the
out
work, I
about.
just walk away.
I don't know
Sorry,
if you can hear
somebody
me.
is talking. I'm not hearing you.
Okay.
Okay,
I
continue.
was wondering if, okay, during the course of your presentation, you were trying to tell us how to go about the frequency of contraction, the timing, and all of that.
Yes.
I wasn't able to get it properly. I don't know if you can throw more light on that, please.
Okay.
Thank you.
So you have to be conversant with the assessment.
Auntie,
So
because once it starts becoming viable, and that's what I was saying. That's what I said to my mom too. That's why it is,
somebody is
and that's
talking.
why I
Please, can
need the
you
equity
mute
Please
because
them?
I'm
mute
purchasing the
yourself.
building.
Please
And
mute yourself.
They'll be discussing inside this thing.
in a building.
Can you, Dre, please, can you mute them?
Then,
The host, can you mute them? This person that, okay, she has unmuted herself. Yes. So during assessment, sorry, during assessment, you have to assess the power using modified Oxford grading. That's a power of 3. Then for the endurance, you have to insert your finger. So when you insert your finger, one of the finger, then you now ask the patient to contract, maximum contraction, maximum voluntary contraction without using any accessory muscle. So when the patient contract the muscle, then you now count the number of seconds that she is able to hold that contraction, maximum contraction. Maybe she can do that for up to 5 seconds. Then you now ask her to repeat this contraction, maximum voluntary contraction. Contract, for 5 seconds that you now observe at the endurance stage. She should now contract for 5 seconds, relax for 5 seconds, and you now continue counting. How many times can she be able to do this contraction? So if she can be able to repeat this same maximum contraction, hold for 5 seconds, relax for 5 seconds, and she is able to do it for, let's say, 7 seconds, for 7 times. That means she can repeat this maximum contraction, that's the R, for 5 times. And for the F, she should repeat this maximum contraction. This one, how fast she can contract and relax without the patient counting the seconds. Just contract, relax, how fast she can do this maximum voluntary contraction. Then you will now be counting. She contract, relax 1, contract, relax 2, up to the number of times. Let's say she can do that maybe 10. So then you now come back. This is assessment. Then you come back and now design the management. How you will do it is, for the strength, you now use, instead of you to take, she can be able to contract maximally and hold it for 5 seconds initially. So that means the muscle is fatigued at 5 seconds. Then you now take 50 to 70% of 5, which is just like 3. So, and she can repeat that 5, contract and relax for 5 times, or we said 7 times or so. Then you also take 50 to 70% of it. We don't want the muscle to go into fatigue. That is why we are now using maximum repetition
Okay.
maximum. So the you now take like 5. So that means she can contract and hold for 3 seconds. Then she will relax for 3 seconds, and she can now do this and repeat it for 5 times. And that she should do it 3 to 5 times a day. Then for the endurance, she will do endurance training once in a day, but this one she will now do past contraction, contract and relax, contract and relax. Instead of taking up to the 9 times that she did, then we will now take 50 to 70% of 9, which is like 7. Then she will do fast contraction 7 times every day. Did you understand now?
Yes, I do, ma. Thank you so much, ma.
Yes. So this is how you prescribe to each patient.
Okay, ma. Thank you, ma.
Yes. Is there any question again? Comment or contribution? Question, comment, contribution.
Thank you so much.
Yes, ma.
We really appreciate the presentation. I actually have one important comment to make, which is very vital. I don't know, maybe it skipped my mind or because of my network. I don't know if you mentioned that about patient consent in terms of assessing the patient by getting into contact with the patient, because this involves intimately using the fingers to assess. So that patient consent is very vital and necessary. I don't know, maybe you mentioned that.
Yes, I skipped it because I thought the first presenter would have taken that aspect.
No, because it's the treatment plan, treatment aspect. For
Okay.
treatment to
So
address.
yes, let me say it. But for treatment and but for assessment and treatment, patient education is very vital. After educating the patient, you now explain the procedure of what you are about doing, how to do the assessment and the treatment. Then you now give either verbal or written consent for the patient to sign. If she consented, then you will now start with the assessment and the management. If you did not do that, because I have a patient that after she consented, she is a divorcee at I think 19 year or 20 years, I've forgotten. Then she now went home and explained the procedure to her mother. The mother now explained it to the father. Then the father declined the treatment, saying how will she be exposing herself outside the home. So, and there is no how we can do than just to continue it the way she wants. So consent is very important, please.
Thank you very much.
Yes.
Secondly, is there any point that physiotherapy management might seems to be not that necessary, and the only option is surgery, or it can be cured completely or managed completely via physiotherapy only?
Yes. Why I said yes, because most urinary incontinence condition are preventable and treatable and curable. The only time is the patient has to go for surgery is when there is involvement of the maybe there is a disease condition or blockage or retention or something that is worsening the condition. But if there is nothing like that, it's just the normal urinary incontinence that we know, please let's even advise the patient not to go for surgery, because the surgery, so many literatures are saying that the surgery only lasts for maximum 1 year. And there is another thing, that any muscle that is severed, it reduces its muscle power by 1. So this muscle, the pelvic floor muscle, the sphincters, and the rest that are weak, then you now take it to surgery. The surgery will now tempered or severed the muscle, do sutures and the rest. Then the muscle power will now reduce again. Though the patient will be continent for a while, but the patient will still come back with severeness of the condition. So we advise the patient to continue management. That is why you have to be telling the patient, even if the patient um, becomes continent, should continue with exercises. Thank you.
Thank you very much. I think this part is very vital for all of us in order to treat our patients in
Yes.
terms of going into surgery quickly without being patient to see the outcome of physiotherapy. Thank you
Yes.
very much.
Yes. All pelvic floor muscle dysfunction should not go under the knife, please. Unless like the third degree prolapse, that you see the uterus protruding out. Please, they shouldn't allow the patient to go under the knife. Thank you.
Thank you so much.
Hello?
Hello.
Thank you, Ma.
Thank you, sir.
So, appreciation, we appreciate your presentation here. But
Thank you,
what's
sir.
your view about a male physiotherapist handling this type of case?
Yes. So
Because there are some instances that some patients will decline or feel somehow apprehensive that a male physiotherapist should see them for this case. What do you think? Because when we have maybe only the male physiotherapist that is very highly experienced in that case. So what do you think about this? That's what my contention now.
what you are saying is that when there is no female therapist to see female patient.
Yeah.
Yes, yes. Even here, we used to face this difficulty, and in fact, there was a time I wanted to travel out to search for where I can do something about women's health. Most even in the developed countries will be saying that if you I want to come, you come with a vagina. Yes. So in the absence, even we have somebody now, Dr. Jane, that went to UK to practice physiotherapy. This is the same problem she is facing. That most even the female will not even consent to a female to see her because she don't want to be exposed. You see, all women health condition are the way I used to say it's are cosmetic things. All our mothers live with this condition. They didn't bother, and grandmothers, they didn't bother to come to the hospital to assess medical care. They just feel that the moment you've given birth or you are married, so you must have these conditions. But with advancement in knowledge and rest, that is when we now come to know how physiotherapists can do all these things. But female will not allow male to, yes, unless it
This is breaking. The network is breaking.
Hello.
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 Maybe she has some network issues.
Probably.
Yes.
Sorry, I think our network is somehow technically faulty. Maybe you exit and come back.
Hello.
Yes, you are back now.
Hello.
Yeah, we can hear you.
Yes, ma. Yes, we can hear you, ma.
Hello.
Yes, we
Can
can
hear
hear
you.
you.
Can you hear me?
Yes,
Yes.
we can. I'm hearing you.
Okay, so as I was saying, this is very challenging, and there is no how we can do about it. It's just for us to continue awareness so that people will now understand. And at times, you will find a patient that is desperate. So, if the patient is willing to, and the patient will not mind a male therapist seeing her, that means you can go ahead. But if not, you have to bear with the patient, just give treatment the way they want. And still, if she can understand, she can, and there is no how you can do it. Thank you.
Good afternoon. Thank you, Miss Presenter, for an amazing presentation. I just would like to just add to what you've said in terms of the when you have just a male physiotherapist. In certain institutions, they advise sometimes you can have like a female nurse in the room,
Yes. Yes.
or you can ask the patient if they have a relation whom they are close to and feel safe with that can be in the room as well. So I think giving them those options as well
Yes.
can
Yes.
reduce the fear, or the make the avoid situations that make them uncomfortable. So I think that's also an avenue to explore as a male physiotherapist as well. Thank
Yes.
you.
Yes. Yes. That's a very good. Um,
One other thing I forgot to mention, sorry. We've had these situations where sometimes the male physios themselves can be uncomfortable and try and feel like they have to make jokes to make the patient calm. But sometimes
yes.
that can be a ticking time bomb. You shouldn't do that. You should just read the room. It's not everything. If you as a physio yourself is uncomfortable doing that, I think that's the first point of, you should be aware of yourself as well. And you should know if you are actually ready to do that. If not, don't put yourself and the patient in a very uncomfortable situation. Thank you.
Yes, yes. This is also very important. Thank you for your contribution. Do we still have question, comment, or contribution, please?
Hello, ma'am.
Hello, sir.
Okay, ma'am, please, I wanted to ask, this condition, urinary incontinence, we know it also occurs in male, not just female patient as well. So is this same assessment, same treatment that applies to the male patient as well?
Yes, sir. It's just that the assessment, instead of going through the vagina, for the males, you go through the rectum.
Okay, ma'am. Thank you, ma'am.
Yes, sir. Questions, comment, contribution. If you have any, please, you are free to. Dr. Samani or Dr. Hafiz? I think there are no questions again.
Yes, I think we have addressed the question.
You said?
I think no more questions open.
Yes.
So I think
We can't hear you. We can't hear you.
We cannot hear what you are saying.
okay. What of now, please?
Yes.
Okay, now.
I think the question and the comment have been exhausted virtually. So, in the absence of any further questions or comments, we want to thank the center for doing justice topic. Question.
We're not hearing you.
Okay. You can hear me still?
Yes.
What of now? Can you hear me now?
Yes, we can hear you.
Okay, sorry. I said we without further questions and comments from the participants, we want to sincerely thank the presenter, both the first and second presenter, for doing justice to the topic. And we do hope to see you again in our subsequent presentations coming. And then we also want to thank the participants for staying all through. We can use the rest of the timing to review the materials. Be rest assured that the PowerPoint and other necessary materials will be shared via the WhatsApp platform for this workshop. And thank you all for joining us, and hoping to see you in our subsequent workshops in future. Thank you all.
Thank you. And thank you.
Thank you.
Is it the end?
Yes, please. Yes.
Hello, ma.
Hello.
Hello.
Yes,
sorry,
please.
my question is coming a little late, but I think I need a little clarification in something.
Oh, we are close, but what is that?
Yes, sorry about that. Do you think it's relevant for someone that is going through the therapy for urinary incontinence? Are you supposed to advise the patient for the meantime during the process of the treatment to abstain from sexual intercourse? Hello?
No.
Yes, I think the presenter is still with us. She will attend to your question, I think.
Okay, thank you. Yeah? Yeah? Pain? Has she left already?
I guess. I think what you can do, just forward your question to my WhatsApp or to the WhatsApp group of the platform. Then we forward to her. Then when the response, we get it to you. Thanks.
All right, thank you.
Welcome. Thank you.